Hello. Today we're discussing a complex topic, mitral regurgitation. In this syndrome, blood flows backwards from the left ventricle to the left atrium during systole. Considering primary versus secondary mitral regurgitation, in order to treat mitral regurgitation effectively, we must first separate it into two mechanistic buckets. Primary MR involves intrinsic disease of the leaflets or cords, such as degenerative prolapse or rheumatic restriction. Secondary MR occurs when the leaflets are structurally normal, but changes in the ventricle or atrium alter the closing forces. This distinction dictates our entire therapeutic approach, and it predicts durability and guiding therapy. In treating MR, acuity matters immensely. Chronic MR causes progressive heart remodeling, while acute severe MR often leads to flash pulmonary edema and cardiogenic shock because the non-compliant atrium cannot handle the sudden retrograde volume of blood. We often use a Carpentier functional classification to link the physical mechanism to a surgical strategy. Type 1 Carpentier abnormality features normal leaflet motion, often due to annular dilatation. Type 2 involves excess motion, like a prolapsing of flail leaflet from caudal rupture. Type 3 indicates restricted leaflet motion. Type 3A is restricted in both systole and diastole, classically seen in rheumatic heart disease. Type 3B, on the other hand, is the hallmark of leaflet tethering from a remodeled left ventricle in ischemic or dilated cardiomyopathy. Increasing tenting forces underlie the physics of failure, and this failure is dynamic in nature. We should recall that the posteromedial papillary muscle often relies on a single blood supply from the RCA or RPDA. Abrupt severe mitral regurgitation due to papillary muscle rupture is catastrophic, usually presenting post-MI, and mortality is historically 80% without surgery. Immediate afterload reduction and emergent surgery can save lives in this situation. For a moment, let's talk about assessment. While a classic holosystolic apical murmur can suggest significant chronic MR, clinical exam alone is insufficient. Acute severe MR may present with a surprisingly soft or short murmur due to rapid pressure equalization. We therefore rely heavily on imaging and an integrative diagnostic approach. Now, ponder AFib or heart failure preserved ejection fraction. In both these situations, there is severe left atrial enlargement. AFib causes annular dilatation that prevents leaflet coaptation, leading to MR. MR dilates the left atrium further, causing more annular dilatation and worsening MR. Thus, long-standing AFib and heart failure preserved ejection fraction drives severe LA enlargement, driving the MR. Therefore, whenever we manage mitral regurgitation, we also have to concomitantly manage atrial fibrillation. This is both a consequence of and a driver of the mitral regurg. Contemporary surgical techniques strongly recommend adding a surgical ablation procedure and managing the left atrial appendage during non-emergent mitral surgery. This significantly improves patient freedom from AFib at 1 year and also negates the need for anticoagulation long term. Now, first line imaging includes echocardiography, starting with transthoracic echocardiography. This is our foundational first line tool. Guidelines mandate an integrative approach to quantification, including using murmurs such as effective regurgitant orifice area of 0.4 or more, or a regurgitant volume of 60 milliliters or more to define severe MR. Advanced imaging for complex cases when transthoracic imaging is inconclusive or we are planning complex procedures include TEE with 3D echo. 3D TEE is invaluable for localizing prolapse and planning transcatheter device positioning. Furthermore, if echo data is discordant, cardiac MRI is recommended for precise volumetric quantification and fibrosis characterization. Intervening in primary MR is to relieve symptoms and prevent irreversible ventricular injury. Triggers for surgery include ejection fraction dropping to 60% or end systolic dimension reaching 40 millimeters. In addition, the 2025 European guidelines strongly support early repair in asymptomatic low-risk patients if markers like atrial fibrillation or pulmonary hypertension are present and a durable repair is highly likely. Secondary MR management involves a different physiological thought. The foundational therapy here is optimized GDMT and cardiac resynchronization therapy if indicated. We only move to structural interventions when severe symptoms persist despite maximum tolerated medical management. Considering repair versus replacement, when it comes to surgery, repair is the gold standard for degenerative primary MR due to better long-term outcomes and the avoidance of prosthesis-related complications. But in ischemic or functional MR, randomized data shows a caudal sparing replacement may result in far less MR recurrence than repair. Now, moving on to edge-to-edge repair. The evidence for transcatheter edge-to-edge repair for symptomatic secondary MR patients has been steadily building. The COAPT trial showed a sustained reduction in heart failure hospitalization and mortality through 5 years. However, the Mitral FR trial showed no benefit, reminding us that TEER only works if the primary driver is the valve lesion rather than advanced irreversible ventricular disease. Acute is severe ischemic MR, such as from papillary muscle rupture after myocardial infarction, is a time-sensitive emergency. These patients face extraordinarily high mortality, require immediate hemodynamic stabilization, often with mechanical circulatory support as a bridge to definitive emergency surgery. The transcatheter options are expanding beyond TEER. The percutaneous landscape includes transcatheter annuloplasty devices such as Carilion and Cardiaband, as well as transcatheter mitral replacement or TMVR for high-risk patients, failed rings, or those with severe annular calcification. In conclusion, mitral regurgitation therapy includes precise understanding of etiology, integrative approach to imaging, nuanced application of medical, surgical, and transcatheter therapies. By matching the exact phenotype to the right intervention at the optimal time, we can significantly improve patient survival and mitigate structural damage to the heart. Now, this talk should be by no means considered a definitive comprehensive talk, rather an introduction. Thank you for watching. More to follow.